Hello, everyone, and welcome back to Pharmacology with Dr. Sokolow. So we are still in the principle of pharmacology. This is the third module, and we are still focusing on those basic concepts and background of pharmacology. And if you remember last time, we ended the lecture with the characteristic of the commonly used, that we were going to go through the characteristic of the commonly used routes of administration. So the different routes of administration are parenteral and enteral. And these are the example of oral form. You have tablet, enterocoded preparation, sustained release preparation, and we'll see this in more detail as we move along this module. And then for the parenteral, you have the intravenous, the intramuscular, and the subcu. So the route, as you know, that is going to affect the onset and the intensity of the drug effect. And this is why, you're going to prefer parenteral route for emergency situation compared to the enteral route. So let's start with the intravenous administration. In that situation, you have no barrier of absorption, none, because you stick the needle and it's straight into the vein of the patient, straight, the drug goes straight in the blood. So the absorption pattern, it's instantaneous and complete, which means, virtually all of the administered dose reaches the blood. Now, the advantage, it's the rapid onset and the control over the blood level. You can adjust like the drip, so like how much of your drug is injected per minute or per second, which you cannot really control with a oral or parenteral, with an oral medication. And other advantage, you can use large volume of fluid. So here are some different bags. You have like small one that can go from 50 milliliter to the large one up to like 1 liter. And so depending on the rate of infusion that you want, you can use a smaller or a larger bag. Now, another advantage, you can use this method for irritant drug, like chemo drug, because the blood flow is so intense that the drug will be washed out from the site of injection really quickly, and then you're going to have, minor cause of local injury that you would see more with a drug that is injected intramuscularly or subcu. Now, the disadvantage is the high cost and the difficulty, the inconvenience. This is mainly for the hospital settings, because you need to have skilled nurses or physician that can administer those medication IV, and that also reduce the mobility once you are hooked up to one of those IV device. Irreversibility, this is very dangerous because once the drug is in the blood, there is no way you can remove it. It's injected, and that's why some drug has to be injected slower than other, just to avoid the toxicity. Vancomycin, which is an antibiotic that is commonly used in the hospital setting to treat, resistant bacteria. You want the rate to be lower than 10 milligram per minute to avoid, toxicity. Now you can have fluid overload, and this is can be a problem with some patient. For example, patient with heart failure that already have like problem of fluid retention, or patient who has kidney disease. So if you inject them, an additional source of fluid that can cause fluid overload. But again, you have to weigh the benefits versus the disadvantages. And patient with heart failure, we need like an emergency drug, it will still be injected by IV. No, it can be a source of infection, because you stick a needle straight in the vein. You have to make sure that everything is really well sterilized, that you disinfect well the area where you're going to inject before injecting the drug, and make sure that the preparation that you are going to inject is sterile. Always look if there is no, also, yeah, for the next step, you want to look that there is no particle that is floating in your vial that you may mix with your bag, or either if it's a small vial that you need to inject, make sure that it's totally clear, because if you have some particle that can cause an embolism, it's going to clot in the vessel and then create an embolism. So what is an embolism? In case you don't know, it's a blood vessel blockage by a clot or a foreign material or an indissolved drug. So it's very important every time you inject a IV medication, look for the clarity of your solution. Now, if you have insoluble drug, you are going to give them IM rather than IV. Then you want to check also the IV compatibility. Make sure if you have to administer two different type of drugs that they are compatible. And I'm giving you some references here. And this is more something that will be discussed in your MedSearch courses, but I wanted to include those IV compatibility website where you can check, if you have those two drugs, argatroban and metronidazole IV, just input them in this website and then click analyze to see if they are compatible. Other example, amiodarone and digoxin, vancomycin and septaz, and then you can look at their compatibility. Um, Intramuscular. So intramuscular, this is you're going to have like a small barrier of absorption, which is not really a problem because the only barrier you have between your muscle and the capillaries that are vascularized, that is the vascularization of your muscle. You see that those capillary has small holes, and so the drug, when you inject them intramuscularly, they are going to go through the blood flow through those little holes. They don't really need to cross the membrane in order to reach the blood flow. So the drug can pass from the muscle to the blood flow, and again, when you reach the site of action, it will exit the vasculature by the same mechanism and use those little space between the capillary cell, and do not have to cross the cell membrane to enter the bloodstream. Now, intramuscular, the absorption pattern, some may be rapid, some may be slow. So what is going to determine the rapidity of the absorption is going to be the water solubility of the drug and the blood flow at the site of ejection. So if you have a muscle that is well perfused, then it's going to be, going to the capillary faster, and then it's going to move on faster. And water solubility, again, if your drug is already soluble, it's going to be absorbed faster. What are the advantages? This intramuscular route can be used for parenteral administration of drugs that are poorly soluble in water, because remember, when you have a IV injection, you want to have a crystal clear solution. You don't want to have any particle to put in the vein, otherwise you can have an embolism. And so that alternative for those drugs that are not as water soluble, you can inject them intramuscularly. And that's the case for the depot preparation, for which the drug is absorbed slowly over an extended period of time. If you have the chance to inject one of those, you will see that it's not totally soluble, but then it's going to, once it's injected, it's going to solubilize slowly, and then you're going to have like a slow release, which means, you're going to have a delayed absorption, and the effect is going to remain longer. So the effect is going to persist for a day, week, or months, depending on the preparation. And so this is Some of those depot preparation are used in some birth control and other in antipsychotic because patients with psychosis are not always easy to convince to take their medication orally. And then sometimes, they are receiving an intramuscular injection of their antipsychotic meds that is going to last for several days or weeks for patients who are poorly compliant with the oral medication. The disadvantage, we all know, we all had our flu shot this season, and we know you have like some discomfort at the site of injection, but it disappear, after a day usually. Now the volume that you can inject by the intramuscular route is different from the volume that you can inject IV. So you see here your syringes, they are like 5 milliliter, 2 milliliter, depending on where the drug is going to be injected. So you know that the glut region, the butts, are bigger, so you can inject a larger volume, like 5 mil. But in the deltoid of the arm, where you do, the flu shot, this you can inject like 2 milliliters. And IV, you have different type of IV. You have the bolus injection, which is a small volume, like a direct injection. You don't have to set up like an infusion with an infusion rate. And then you have the infusion, which is set as a maximum of 35 to 50 milliliter per kilo of body weight, because again, you're injecting some extracellular fluid, and you don't want an overload of fluid in your patient. And then the amount of drug delivered is going to depend on the rate of infusion and depend on the drug and the toxicity of the drug. If a drug is toxic, you're going to set up a low rate of infusion, and also you're going to inject less drug in those infusion. So example, antibiotic, saying almost every single patient in the hospital is getting at some point an antibiotic perfusion or infusion, or patient, they receive painkiller, morphine. Now, conversion rate, this is also informative, but as you know, the metric system is the system that is used in with drugs. The drugs always express in milligram, gram, microgram, and then also express as per the body weight of the patient, and the body weight of the patient has to be calculated in kilograms. So the first thing you have to convert is like the weight of your patient that you're going to assess in pounds, and then you have to convert that into kilogram. So 1 kilogram is equal to 2.2 pounds. So if you have a patient that weighs 220 pounds, that means it's going to weigh 100 kilos, because 2.2 pounds, it's equal 1 kilo. So you have to divide the weight in pounds divided by 2.2 to convert into kilogram. And then if you see that, the patient needs to have 10 milligram of that drug per kilo. So if the patient weigh 100 kilo, you're going to have 10 milligram times 100, which is 1000 milligram, or it's equal to 1 gram. So that would be the dosing for your patient. Other, reminder like kilogram, and it's 1000 time of the basic unit. Milligram is 1000th time of the basic unit, and microgram is 1 millionth time of the basic unit. So I have this here, but you won't be questioned about those conversion in my class, but I think it's good to remind you those conversion factors. Now, sub-Q administration, this is the route of insulin. So patients who are on insulin replacement therapy, their insulin is administered sub-Q, or patients who are receiving heparin to prevent, DVTs, this is also given sub-Q. So the route of administration is almost nearly identical to the intramuscular route. There is no significant barrier to absorption. It's a little bit slower absorption because there is not as much blood flow as you have in your muscle. Now, the oral administration, PO per os, that's where you have a big barrier to absorption. And the absorption, as I mentioned in the previous module, can occur either in the stomach or in the intestine. So in either case, the drug is going to have to cross two barriers. It's going to have to cross the GI epithelial cells, the membrane of the epithelial cells, and then the capillary wall. But as we said, the capillary wall is not a problem because you have those gaps between the cells, and so it doesn't really have to cross the membrane. But the resistance, the major barrier is the one in the GI epithelial cell, whether it's in the stomach or in the intestine. And so the drug must pass through those cells. Now, with the oral administration, you have to take into account the absorption pattern and the difference of the variability of that pattern based on the solubility and the stability of the drug. So as I mentioned, if a drug is solubilized fast, dissolve fast from the inactive ingredient and get solubilized fast in water, that's going to increase the absorption pattern and then the amount of the drug that will reach the receptor. Now you have to remember also the pH partitioning, knowing that the pH in the stomach is more acidic than the pH in the intestine, and remember the concept of weak acid, weak base, which one is going to be more ionized in which pH. The gastric emptying time is also a factor that is going to affect the absorption pattern. And this is why for some drug, it is important to educate the patient whether or not they should take the medication with a meal. In some case, it's good for the patient to take the drug with a meal because it will slow down the absorption of the drug and then therefore reduce the toxicity. In some other case, you don't want to have food eaten with at the same time as the drug, and you tell the patient, okay, this one you have to take it within 20 minutes of a meal because the gastric emptying time can affect the absorption pattern. After you eat, your stomach, the time to empty your stomach is different than when you're on an empty stomach. So same thing, the amount of food, the type of food, some food can interact with the drug in the gut. And then co-administration of the drug. You can have drug-drug interaction also in the GI. Drug-drug interaction, you have some, like let's say your patient is taking an anti-acid with another drug, and the anti-acid is going to modify the pH of the stomach. And if the drug is absorbed well in the stomach, that can accelerate, the rate of absorption right there. So, but most of the drug-drug interaction are going to be related to the metabolism. And so there are some special coatings of the drug that can help with the absorption pattern. So let's say if you have a drug that is very sensitive to the pH in the stomach, you can, when the drug is developed, when the formulation is made, they can put a special coating. So the capsule, the tablet is not going to disintegrate in the stomach, but will only disintegrate when it goes down to the intestine. And another factor that can influence the pattern of absorption of the drug is the first pass elimination. So if you remember one of the slides that I showed you in one of the previous module showing that the drug can be delivered from the bloodstream to the site of action, but also at the same time, you still have some of the drug that is going to be metabolized in the liver. So if a lot of that drug is metabolized in the liver before it reaches the site of action, you're not going to have much of an effect. Again, this is going to be determined during the clinical trial, but it's also important to know which drug has an important first pass elimination when you are treating a patient with liver failure, because this can affect the pattern of the drug in those patients. So if you have a drug that is metabolized efficiently by the liver, that means it's going to be removed from the circulation before even being distributed to to the body right there. So that means you would have to give a larger dose and or have a drug, sometimes drugs are metabolized in the liver into an active ingredient. And again, this is determined in the clinical trial. um, or if that drug cannot bypass the liver function, but it's very unique drugs, and there is a need for that drug, like let's say nitroglycerin NTG, which is heavily metabolized in the liver. You have the sublingual form. So patient who has like a acute angina, they will put their sublingual pill under their tongue, and it will be going straight to the circulation, and we'll see an effect, because if they would take it on a regular tablet, they would not get much, and so they may die of a heart attack. So these are drugs that are heavily metabolized by the liver. It doesn't mean that they are not used. It's just what we know, because we know that they are heavily metabolized in the liver. I mean, in order to have an effect, the patient is going to need a higher dose, and those doses, again, they are determined in the clinical trial. So aspirin, morphine, meperidine, estrogen, these are drugs that are heavily metabolized in the liver and has a high first pass elimination. Now you have the enteropathic recirculation. So what we saw previously is like the first pass elimination would eliminate the drug from the liver, even reaching the target, and then dosing needed to be taken into account when it was determined because of that heavy first pass elimination. Now there is another path that is also looked at in the drug development, is the enteropathic recirculation, because in that case, so you see the drug is metabolized and then excreted in the bile, but then it's going to be reabsorbed by the GI tract, and then again will be reaching the liver to the portal vein, and then some will go to the bloodstream and distribute to the general circulation to reach the target. And so this is just going to extend the amount of time that the drug will remain in the body, because instead of being excreted, it's being recirculated. So you see, just extend the amount of time that the drug stays in the body. So those drugs are going to have long half-life, the time that is determine like how long the drug stays in your body. And this can be a factor for those drugs that has a long half-life, is because the drug is reabsorbed into the portal vein and then creates this enterohepatic recirculation. And then ultimately you can have some that is exiting the body in the stool, rather than getting further distributed to the kidney and metabolized and excreted in the kidney. So what are the advantages and the disadvantages of the oral administration? Main advantages: easy, convenient, inexpensive. That's why most of the drugs are given per os, and they are safer than parenteral. So we saw previously that parenteral, you inject the drug straight in the bloodstream. And so that's the preferred route for self-administration, because it doesn't require some skill, personal to do an injection, like compared to a drug that is injected. Anybody, can swallow, can take a drug per us. The disadvantages is the variability, and the absorption can be highly variable. Um, Inactivation, some drugs can be inactivated in the stomach. Um, and then it has the patient requirement, because the patient has to be compliant and conscious. There's a reason why you would give a parenteral drug. It's if your patient is unconscious and cannot swallow a drug, you will give the patient a drug via parenteral route. And then local irritation, so you know that some drug can be more irritant to the GI tract than others. So that's an example. All the NSAID, like the painkillers, can cause GI discomfort. Your ibuprofen, um, and so you have to be aware of that. So when you are aware of that, um, you know what to do. Of course, some patients will take an anti-acid after taking a NSAID, just to lower their sensitivity to the medication. Now, what are the different oral formulation? So the most common is the tablets, which is a mixture of the drug plus some binders and fillers that are compressed together. So those agent that makes the drug, the active ingredient, to stick with the non-active ingredient. And like I discussed in the one of the previous model, is the chemical equivalence. So how do we know if two preparation that contain the same amount of the identical compounds are bioequivalent? So if you have two generic, or if you have a generic versus a brand tablet, are they equivalent? And last, in one of the previous module, I showed you where you can find those information to see if those two preparation are bioequivalent. Of course, this is the physician who's going to check that information for the patient before prescribing a bioequivalent. But you may have, a patient asking you, oh, my physician switched me to this other generic, and I feel like it's not the same, and you can go and check and see if they are bioequivalent. So and that's why, when you say some formulation may be chemically equivalent but not bioequivalent, because they have the same amount of drugs, but it's just because the inactive ingredients are not the same, and that's why you may not have the same response. No, the enteric coating. So as I said, there are some drugs that can be very sensitive to the acid in the stomach, and so there are some enteric coating. You've probably seen that if you look for like an aspirin or even an ibuprofen, where it says, oh, it's enteric coated. It's because those drugs are more sensitive, or they may be irritant to the stomach. So by putting an enteric coating, that means the tablet is not going to be, this coating is going to be resistant to the acidity of the stomach, and is not going to dissolve in the stomach, but will only dissolve in the intestine, and so will reduce the irritation caused by that medication in the stomach. So to protect the drug somehow, some drug can be sensitive to the acidic pH, and then other can be used to protect the stomach from the acidity of that molecule. And lastly, you have the sustained release preparation. You probably heard Excel or LA, not for Los Angeles, but for long acting. Those preparations are made of capsules that are filled with microspheres that contain the drug. So you have a capsule that is filled with those little beads that, you can even see the difference with your eye, but they are like micro beads, and they have different size. And so the smaller one are going to dissolve faster than the larger one, and that's how you can have a long acting effect or an extended release, is because each little bead is going to dissolve at a different speed. And so, yeah, that one is very important to know that you cannot crush those extended release or long acting, and you have to educate the patient to tell them do not crush your beads, because if you crush those, they would say, oh, I'm just going to open my capsule and then I'm going to crush. What you're gonna do is, like, instead of having an extended release, then you're gonna have an immediate release, and you can have a serious adverse effect occurring, because now you are giving the amount of drug that was supposed to be given, that was supposed to last, let's say, for 8 hours, but now everything is going to get to the bloodstream at one, at the same time point, and so you're going to have a higher drug concentration. So do not crush extended release or long acting for the safety of your patient. Now, what are the difference between parenteral versus oral administration? Parenterals, if you have an emergency that required a rapid onset of cold blue drug, of course, you want to give a parenteral, you want to give it by parenteral route. Now, if you have a situation in which you really need a tight control, like in an hypertensive crisis, you can also, have that tight control with parenteral route. As I said, you can, adjust, like, the rate of infusion with a parenteral when a drug is administered parenterally. Now, protein drugs, protein that you have in a meal or protein that is in a drug, your body doesn't know the difference. A protein is a protein for the body, and so your body is going to degrade your protein drug the same way it degrades your steak. So all those protein drugs, that's why they are given parenterally. Insulin, insulin has to be administered subcutaneously, and then, in emergency situation, there are some IV infusion of insulin. Other example is ApoE alpha, EPO, and now, we're talking about antibody cocktail for the treatment of COVID-19. So those antibodies are protein. Again, they cannot be taken orally, otherwise they would be useless, they will be degraded, and again, the same way as you degrade your steak. So that's why, if you have a question on the board exam, or is this drug can that drug be administered orally? Everything that is going to be protein, antibodies, no, it's only parenterally. Now, drugs that are irritant, like, the chemo drug, they are going to be administered parenterally for the reason that I mentioned previously. Drug that cannot cross the membrane, so I said that also in another module, like the quaternary ammonium, or like the vicuronium, because they are charged, they cannot cross the membrane, so they have to be given parenterally. Drug where you need a prolonged effect, like dipomedrol, drug that is used either as a contraceptive. This is a form where, instead of taking an oral contraceptive once a day, there would be an injection that will last for several weeks. Some other can even last for several months. Because, again, the drugs stabilize at different pace and then release a little bit at a time, and that's why you have that prolonged effect. And of course, if you have an unconscious patient, or, as I said, with a psychotic patient that are not cooperative or are not compliant with their medication, the parenteral route is a way to give them the medication they need less frequently, and increase their compliance, and treat their disease. Now, there are other route of administration, like the topical and the transdermal. What is a topical? So a topical can be a cream, one that's used, for example, for hormone replacement therapy, either in men or women, testosterone cream, or for women who need to have estrogen replacement. So there are some estrogen cream. Transdermal, so it's the patch. This is a big advantage. Again, you bypass the membrane, and those patch also can provide like a longer acting. When you talk about, when we'll talk about ADHD, you know, you have those patches that also better to reduce, you know, like the ups and down, because you have like a more steady release of your medication, like a slower release, and you don't have ups and downs in the effect of the drug. And then you have fentanyl patch, you know, a painkiller. Inhalation, these are the preferred route for, of course, the upper respiratory tract. And for patients who are suffering of asthma, like the albuterol, the Prohair, Ventolin, and then you have the Advair. These are a route to treat directly where you need the drug to go. Now you have some, you know, less common form of injection, like direct injection in the joint, in the nerves, in the central nervous system, in the heart. But those, as you can imagine, also required a very skilled provider. And then other routes that we should not forget are the rectal and the vaginal suppository. Vaginal suppository, very common to treat you know, vaginal infection, mycosis, and then the rectal form can be used to treat hemorrhoids. And that's it for this module. I hope you enjoy. And again, we will discuss this in class. If you have any question, we'll go over some of the topics that are harder to digest with this pre-recorded lecture. And thank you for watching.